would like to be posed.
Thank you very much. Please go ahead.
Yes, I was saying, looking at the woman's status, her being not married, it could pose a very big challenge on her, stigmatizing herself, and also understanding the population that she's in could also help her or help us to understand how we're going to carry on with the counseling. So she could be a key population who would have been picking treatment from elsewhere and didn't want to disclose. So the previous speaker just mentioned to say this is a high-risk child that we need to take. So also, group counseling could help this woman accept her status and also help her to actually give the medications to the child who has tested positive. So enrolling her into a caregiver support group can really help her accept.
Contribution, Dr.
Zambia,
can we go ahead?
Yes, thank you. Thank you very much for that contribution, and it's well received. I think talked about being aware of self-stigma, and then a mother could likely be a key population, and hence having difficulties and challenges in disclosing, and then that we should advise for group counseling. Any other contribution from the network?
Good afternoon.
Yes, Dr. Thomas. Good afternoon. Is that still?
Yes. Yes. My name is Sombo. I'm joining from one of the spokes. I've seen that you've got Mr. Mpanji Siwinga from the lab. Am I right?
Yes,
I have a question for you, Mr. Mpanji. What is your comment on the turnaround times for those DBS? Is a late DBS very useful for a patient? What should we, as healthcare workers, expect when we send a DBS? What is acceptable? And when should we raise the red flag when we are waiting for a DBS? Because I feel the DBS is what has contributed to this confusion. Thank you.
All right, okay, thank you very much. So on average, the turnaround time for DBS is seven days. So if you don't expect results within 2 weeks, I think you should set a red flag, because normally within 7 days the results should be sent. But I think the challenge has been that sometimes the results are ready, but then the way the results, the mode of sending the results to the facility, I think that's where the challenge is. The results might be ready, but then there is no communication between the sending facility and the testing lab. So if there's that rapport or there's that linkage between the testing facility and the sending facility, I think it's going to sort out the issue of results. But then on average, the turnaround time is 7 days.
Okay, so thank you very much. I really wanted you to say this, and I think thanks, Dr. Folosh, for making Panji to come out quite earlier than we had anticipated. So any other thoughts before we move on focus on this woman? Yes, Dr. Thomas.
Okay, as this woman wants to stop the child from taking the treatment because she thinks the child is negative. So I think the first thing to tackle is she has to be reaffirmed that the child is positive, because she was a high-risk mother and the 2 DBS was positive. So we have to educate her the implications of that rapid test, which has come negative because the child was on drugs for 13 months, and then the 2 PCR was positive. So the baby is really an infected baby. She has to be reaffirmed that part. And also the implications, if she stops, what will happen to the baby? We have to educate her on all that points, I think. Otherwise, in future, maybe she thinks the child is negative and she can stop the treatment.
Okay, so thank you very much. And I think another contribution coming from AIDC is to ask around her social status and beliefs in regards to what she believes about the treatment and her social standing in society. So, I think it's so bordering on what we are supposed to do for this woman. Now, this is where I wanted Mpanji to really come in and weigh in and tell us about, was it really necessary to recollect the DBS after the rapid tests which came out negative, and when there were already the 2 previous DBS which were positive? So was it necessary for the facility to collect a 3rd DBS?
No. So it wasn't necessary. So the issue is that, maybe not to digress, the issue is that when we determine if a positive result is really positive, is that when you do it once, you have to do it again to determine that if it's really positive, because sometimes a patient can test positive, not because they are really positive, because there are contamination issues within the lab. So in the lab, we're supposed to test a positive result twice, so that we have the issue of, it giving a false positive when the result is a negative. So it wasn't really necessary at this point to do the DBS, considering that in the past experience, they already have a positive result. And then if I'm assuming at this point that in the lab, the sample was tested twice. Then if you look at how sensitive the PCR method is, because once a patient tests out positive, you are looking at 99.9% accuracy in the result. So if you rule out the issue of contamination, then there's no need of us repeating the DBS for the 3rd time.
So in short, the lab would have already made sure that that positive result is positive before it's issued.
Yes.
Okay. Yeah. So I don't know, is there any contribution apart from this? I know the mentors have raised their hands again. Fast mentors, I'm always wondering. Please, the fast mentors, be as fast as you can.
Okay, this is John. Just wanted to find out what MOH is doing when it comes to enforcing the child health protection policy, especially for those mothers who refuse to have their children initiated on the ART.
Wow, that's a very good and tough question. And I bet all the big guns are actually in the mentors orientation meeting. So Dr. Zyongwe, I'll pass it on to you and see if the big guns there could tell us what MOH is doing about child protection.
Dr. Mpeta?
Yes.
Sorry, I missed that.
So there is a question from John that what is MOH doing about child protection issues vis-a-vis parents who refuse their children to be enrolled in treatment or refuse to test as a way of preventing mother-to-child transmission?
Well, that's a very difficult question.
Yes, that's why I passed it on to you, where we've got a lot of
So
MOH.
I think at the moment, the practice is to strengthen support groups and counseling of these women that actually do not want to provide the right care to their children. And I think that's what we need to strengthen. And also the social welfare services, I think, are available for these kinds of situations where a woman is not able to support. So I think the approach at the moment that I see being practiced is more of social support than being more punitive in nature, because we do not have any legal backing or policies that will instill any punitive action on such people. But there are more of supportive structures, and this is where we refer now to for counseling, psychosocial counseling, and other social welfare officers to address some of these issues. That's how I would broadly answer that question.
Okay, thank you very much, and I hope that John and the FAST mentors are now abreast with that development. Thank you very much, Dr. Zyongwe. Is there one more thought? All right.
We have a question.
That's the last one I'm going to allow because we need to move to the didactic presentation. Yes, Dr. Zyongwe.
Good afternoon. This is Chipasha Mumbwe. I have a question regarding the Mwana project that was initially very strong, but currently the picture we're getting in Sesheke is that even the MCH coordinators don't even know the last time they received results through the MOANA program. So I'd like to know what exactly is the problem. But now we're only getting calls for positive DBSs, but then we also need the results to come through for the negative DBSs that we receive. Thank you.
All right, thank you very much. I don't know who I should direct this to, although I would actually still refer it back to that same meeting, because that's where I've seen a congregation of heavyweights when it comes to the HIV program. So anybody who has got thoughts about the MOANA project?
I do not necessarily have the full information, but I think what I know is that there used to be like some form of a software before that would send you an SMS and give you the result that you have for a particular patient. So I think that project was sponsored by, if not UNAIDS, I'm not sure which ones. Sorry? Boston University, yes. Yeah, it was sponsored by that. But I think the other thing the other dimension that has come about is people now are using the lab information management system. So people are able to access results so long you've got internet. So I'm not sure what's happening in Sesheke, if they still are connected to that network. But however, I'm not sure what's happening with Lumona, but they used to provide those services before.
All right, so thank you very much. It was a BU project, and now Mpanji is informing us that now most results are actually being accessed through the laboratory information management system. Would definitely assist you, Chipasha, to discuss with Mpanji to see how Sesheke can be brought on board. So Dallas, I will try to go through what has been discussed here with regards to your two questions, and then you give us feedback if they are clear or not. So the first one with regards to advice giving to the mother is first of all to identify the social issues that are surrounding this mother. Could she be a key population, and hence disclosure is being a problem? So we need to engage her into counseling, and especially disclosure counseling, and also to see how we can assist her with the issue of self-stigma. And then we need, in the same counseling process, to reaffirm the status, the HIV status of the child, so that she understands that this child is indeed infected and needs to be on lifelong ART. The other that is coming strongly is to ensure that we strengthen the support system. As you mentioned, this is a single mother who would definitely need a lot of support in caring for this child, and indeed for herself. As we can see, she's a motivated mother by the fact that she has had 2 suppressed viral loads. Then on the second question, we've been told that it wasn't necessary to do a 3rd DBS because the laboratory always takes care of quality assurance issues. Hence, there was nothing that was going to change after the child had 2 previous DBS which were positive. Is there any further clarifications on the same, Dallas and team? Dallas?
No, not really, though, but we appreciate for the recommendations that have been made, and we shall make sure that we follow them and help the mother.
All right, thank you very much that we haven't confused you. So now we shall move into the didactic session for the day, and to help us present the didactic session is Dr. Nancy Zyongwe. Dr. Zyongwe, where are you now?
It's rather difficult for me to say. I'm in between.
In between jobs?
Yes.
All right. Is it you or me sharing, Chaton?
You share the challenge.
This is a case. No, it's a case. Yeah, it's this one. Okay, so thank you very much. And Dr. Zyongwe, so let's flip there. I'll do it for you.
So good afternoon, everybody. I trust that it has been interesting, particularly listening to the case from Sesheke, Dallas and team. Thank you so much. That was a great presentation and a great case, which actually underpins what we are about to talk about. So this afternoon, we're going to be talking about quality assurance in HIV testing. As you could see, we actually have issues that we need to address. And it's not so much like one of the participants observed what happened at that particular time, but to focus on the quality issues. So our objectives for this afternoon are to review the quality assurance and the rationale for the quality assurance schemes. We'll also be describing the National Quality Assurance System and the need for internal quality control, which we're calling IQC. We'll also be defining the roles and responsibilities of the various stakeholders in quality assurance. And finally, we'll be describing what it is that is expected from our facilities and those our counselors that are actually conducting the testing, or those from the lab indeed. So we have some...
Okay. So we have a few poll questions, and they are as follows. The first one is, which of the following is true? A, misdiagnosis of HIV in Zambia is hypothetical. B, false positive and false negative results are possible after HIV testing by lay counselors only. C, all results are correct as long as internal quality control is passed. And then D, quality assurance can improve accuracy of HIV test results. So please, we can go ahead and vote. So which of the following is true? I'll repeat the question. Which of the following is true? A, misdiagnosis of HIV in Zambia is hypothetical. B, false positive and false negative results are possible after HIV testing by lay counselors only. And then C, all results are correct as long as internal quality control is passed. And D, quality assurance can improve accuracy of HIV test results. So only about 50% have polled. Okay, so about 70%, and most people have gone for D. I will definitely be coming back to that. So we can go to our second poll question. Sorry? Oh, I can launch, all right. So the second poll question, can you flip for me, is which of the following is true? Quality assurance activities are improvements you make after performance results, after performance assessment. B, planning is part of quality assurance. C, quality assurance has many steps, including how the facility is organized. D, quality assurance refers to process control only during testing. Yeah, I'll change it. Okay, so we seem to have a very big disagreement, and I can see only a few have voted. I'm waiting for the fast mentors to vote, because they are very fast, but they are slow now in voting. The fast mentors, I hope you have voted. Okay, so we'll go to the second poll question, the third, rather. Okay, so the third reads, which of the following is false? A, National Reference Lab Procedures, QC specimens, and EQA scheme panels. B, use of a timer during testing is not critical if you are highly experienced in HIV testing. Implementing partners need to be involved in QA activities in their supported facilities. So kindly just note that there's a minor correction there, which reads C, implementing partners need to be involved in QA activities in their supported facilities. Then D, QA teams should be in place at every level. Under your poll question, okay. So I'll repeat the third poll question as we vote. Which of the following is false? National Reference Laboratory Procedures, QC specimens, and EQA scheme panels. QC specimens and EQA scheme panels. B, use of a timer during testing is not critical if you are highly experienced in HIV testing. C, implementing partners need to be involved in QA activities in their supported facilities. And D, QA teams should be in place at every level. Only about 60% of us have voted. Okay, so we'll definitely come back and discuss the answers to these 4 questions. I'll hand over back to Dr. Zyongwe.
Thank you so much. So to start the discussion this afternoon, I just want to tell you something that a colleague of mine experienced and shared with me. So she was going to one of the facilities in Lusaka with another work colleague, and they decided they were going to be a couple because they wanted to provide supportive supervision and they wanted to see how things were done at that particular facility. And so when they got there, she immediately purchased a book where the doctors or the clinicians could write, and they told them to go to a particular room. So she entered and the male colleague was outside. And then she was asked whether she knew what she was doing there. And when she said no, they said, here, you've just come to be tested. So she says, I'm not quite ready. Is it possible I could consult my husband? And they said, we don't even have time to waste. So they grabbed her book. They wrote a negative result because she wanted to consult the husband. And they gave her the book and they said, you can go and be seen. Now, this just shows that really it's not just about poor quality, but there are also some unethical things that are happening, and some are actually bordering on the illegal. And so when you look at the background of quality assurance, we actually see in Zambia that we started in 1991, and our MOH mission has remained the same. It actually emphasizes quality and wants to bring quality as close to the family as possible. Initially, HIV testing was just for trained workers. They used to do the testing, but now we've shared that task with our colleagues, the lay counselors, and they are doing a commendable job. We want to define quality because when you're talking about quality assurance, what is it that you're talking about exactly? So when you look at the American definition of quality, it's doing the right thing at the right time, in the right way, and you want to achieve the best possible results. And so it's not just about what you do, however you do it, but really you want to achieve the best possible results. And so when you move on to now define quality assurance, it's really that step-by-step activity that you actually do to make sure that your results are accurate, that you've done the testing in a correct manner, and that if there are any mistakes whatsoever, you actually avoid adverse outcomes by correcting them in a timely manner. You actually have a system that supports performance according to standards, and this should be in place throughout the entire testing process. when you measure performance against standards, you are talking about quality assurance. So this one is a snapshot just at that particular time. This is how you found the process to be done. The examples that we have up there are just a few of all those that you have for quality assurance. Supportive supervision, SIMS, some of you may have experienced the SIMS visit. There's accreditation, data quality audit, service quality assessments, the core standards audits, or even inspections. So when we're talking about quality assurance, particularly in HIV testing, there are certain things that must be in place. Every quality assurance system must actually have a way that the program is organized. And in organization, we are talking about a focal point person being put in place who's going to coordinate the program. You're talking about leadership that is going to make the decisions. You're talking about someone who's going to make sure that things are going the way they're supposed to. Then you also talk about the testing personnel. Remember that in HIV testing, the most important component is not even the test kit. It is actually the person who is conducting the test. And so these ones need to be competent. They have to be trained. We have to make sure that they are able to provide the test in a safe manner, providing confidentiality, and adhering to the national standards for testing and the guidelines. We also have a testing algorithm. They must become familiar with that. Then when you talk about the process control, you have to make sure that before testing, there are some things that have to be done, and they have to be done during testing and after testing as well. So before testing, you've got things like your pre-test counseling. That has to be done. You've got to get all your commodities and everything you need for the testing in place, and they have to be in the place where you're going to conduct the testing. You can't get up in the middle of testing to go and pick something, maybe a timer or maybe something else. During the testing, you have to do the test. You have to make sure that you have labeled the test strip. You have to make sure that you are giving the service to the correct person. In the after testing, you have to make sure that you do your post-test counseling well. If we don't do the post-test counseling well, this is why we are getting some adverse events after the testing. So I'll give you an example. I went for testing. I didn't really have any reason why I should have gone. It's just that I went to my son's school and they were providing testing. So I walked into the tent. And so when they asked me, I said, well, I just want to know. And so the way she looked at me, the way she was talking, I figured, I think I had made a mistake. And so when she asked me, what do you do? I said, I'm actually a businesswoman. I go to South Africa and I come back. And then she starts to lecture me and she says, you see, you businesswomen, you're very careless. You leave your husbands and then you go and you do other things. And she talked. And at the end, you know, I just sat there and I said, even my own name, I will not give her. So when she asked me, I just gave a name. I gave her just a number. And, you know, the whole experience was just so negative for me. So there are certain things that must happen to make sure that the counseling and the testing that someone undergoes is actually of quality and an accurate result is actually given. And then when you talk about documents and records, you know, a quality assurance system has a lot of documentation, and we have to make sure that these documents are in place. Not only should we have documentation in the register who has visited us today, we should also have the accurate test result. We should also have who we have tested, so we should have testing logs. We should have the consent forms. There are a lot of things that we must have in place in terms of documentation if we are going to say that we have a quality assurance system. Then there must also be troubleshooting. What do we mean by troubleshooting? We are talking about finding problems and resolving them before trouble finds us. So if, for example, our case in Sesheke, we have found that the baby has tested negative after 2 positive DBS, what have we done to make sure that we resolve that problem before trouble finds us? And now trouble has found us, the woman wants the baby to stop, but there are certain things that we can put in place when we have a quality assurance system to identify such problems in time and to resolve them. So this one is a quality assurance cycle. I picked this one from the WHO 5Cs guidelines for HTS. So when you're talking about planning, really, you're just saying that our leadership has put things in place and they know what they want to do. And as a facility, we are actually planning for our services. We've planned to have our test kits in place, so our commodities are in place. We have put everything in place. Then we need to define what our issues are and what we want to achieve. And when we implement quality assurance, we are going to do the things that we have just discussed. And then you monitor to make sure that your system is working well and you're producing the results that you are actually expecting. And when you find there are problems, you actually need to take corrective action. And once you have taken that corrective action, you see that you improve, and then you go back into planning. So it is a cycle and not a linear process, so it doesn't finish. It has to go on throughout the testing and also after the testing. So when we're talking about quality assurance in HIV testing, our case actually says it all, and very, very well. We know that there is misclassification, there is misdiagnosis, just as in our case, and Zambia is not unique. So in Malawi, we had 4.6%. In Zimbabwe, we had 3.8%, and the statistics actually say it all. So what is the rationale? Remember that an HIV test result can have life-altering life consequences. I normally ask myself, today, if they tell me a result that I'm not expecting, how will it be? How will it work for me? So that result stays with you for a lifetime. And we know that we have validated testing algorithms. We know that quality assurance can actually help to reduce the risk of errors, to identify and correct mistakes. When we talk about the National Quality Assurance System, starting from the Ministry of Health, we have two directorates there. There's Performance Improvement and Quality Assurance, which were formed in 2017. And this is because the ministry takes quality issues very seriously, and they've dedicated two directorates to handle this matter. We also have the National Technical Working Group. We also have similar groups that have been formed at subnational level, which also have a role to play in ensuring quality. The framework that is there to ensure that standards are adhered to is also in the process of being finalized as we speak, as well as the National Performance Improvement and Quality Assurance Strategy. So when we talk about internal quality control, remember that a control is actually something which is going to show you that a system is actually working or a test is actually working, and it's going to tell you whether the specimen is of adequate quantity or not. And so a control can either be built into the test, like determine you have your control line, those of you that are conducting HIV testing, or you may have to do it before you actually conduct the test. But more importantly for HIV testing, remember that we have external quality control. And so we have panels, we have some powder that is put in test tubes that people need to reconstitute and then test. And then they need to send the results back to the National Reference Lab. And when they do this, they are able to be marked whether they are providing a quality service or not. And then there's also a system for the 10th client that needs to be sent to the lab after testing 10 clients. This doesn't seem to have worked very well. It doesn't seem to be very practical. I'm not sure in the facilities, all of you that are representing facilities, whether you've actually implemented this or not, and how practical and feasible it is. So when we talk about roles and responsibility, there are many players in assuring quality of HIV testing. The National Reference Lab actually has a critical role to play. They develop the SOPs, they actually produce the quality control specimens, they actually validate the testing algorithms, they also conduct training, among the many responsibilities that they have. But the Ministry of Health, as the policymaker, is also not excluded from quality assurance. They also ensure that testing sites are ready for accreditation. They've established the National HIV Testing Policy, which also includes quality assurance. There's a national coordination team, and they also allocate resources. We've just come from planning. I assure you that there are resources that have been set aside for quality assurance. There are other stakeholders. For instance, you have implementing partners in these facilities. We also have the province, we have the district. So these have also not been left out. These support commodity availability. They have to make sure that availability and adherence to guidelines and SOP is happening. They ensure that the counselors are trained. There's continuous supportive supervision and mentorship. Remember that even our lay counselors are providing testing services now. They also support quality management system. For example, the EQA I talked about, internal quality control, which we spoke about, but also reporting and documentation. So what is it that we expect from facilities? Remember that a lot of these things are happening at facility level. So we expect that at facility level, we'll be able to form a team to coordinate the quality assurance activities. We should have and adhere to HIV test SOPs and guidelines. We need to enroll and participate in the national EQA schemes. We need to keep regular and regularly monitor accurate records. So which records are these? Not just the test results or the DA or the registers, but also the other records that we talked about. We also need to manage our stocks according to the guidelines. If we are able to, we can send the 10th patient to the lab. But above all, we just need to do things in an ethical manner. We need to just make sure that we maintain confidentiality and we provide a quality service and an accurate result. So for the individual counselor, these are the backbone of our testing services. They need to have all the necessary materials. They need to be competent in testing, and the supervisors need to make sure that they are competent. They need to ensure that they are knowledgeable on the testing algorithm, which is part of the competence. They also need to adhere to the SOPs and guidelines, the testing algorithm that we have in Zambia. Then self-supervision on good clinical and ethical practices. For instance, my friend's experience, how do you give a negative result for someone that you have not tested? What happens if they go out with that negative result and infect everybody else when they should have received a positive result and been assisted and their life prolonged? In summary, we know that QA is a system that supports performance according to standards, and it needs to be in place at every level. Misdiagnosis of HIV can happen at any level of healthcare. It can be in a central hospital, a teaching hospital, or in the community, or even at a health facility, despite the experience of the person who is testing. The internal quality controls and external quality audit are actually very important, and they help us to improve the accuracy of our HIV test results. And every level of healthcare has a role to play in QA for HIV testing, particularly the person that is conducting the test.
Okay, so thank you very much for that presentation, Dr. Zyongwe. And I think we are talking about quality, which we know that it's the doing the right thing at the right time in the right way. And we've been told that it's actually a cycle, and all levels are involved, all the way from Ministry of Health up to the individual level. And I think we have learned quite a lot in from today's didactic. I will allow a few questions and clarifications for Dr. Zyongwe before we go back to the poll questions and just try to understand or see if indeed learning has taken place. So anyone from the network who has got a clarification, I can see the hand from where? Okay, those who don't have names, please kindly name your gadgets, but I will start with Philip. Is that Philip? Yes. Philip
Yes, Peter. Good afternoon, and good afternoon, Dr. Zyongwe. Yeah, I've got a concern about proficiency testing. We know that there's some testing taking place in the community as well as at the hospital level. How is the proficiency testing organized, or how is it supposed to be done? Thank you.
All right, thank you for the question. So I'll take one small part and I'll allow Mpanji to answer, seeing that is his domain. In fact, maybe let me just allow him to answer.
Okay. Yeah, please go ahead.
Mpanji, go ahead.
Yeah, so for the proficiency testing, the way it's done, especially for HIV testing in Zambia. So what happens usually is that for the testing facilities, they have to enroll for the EQA program. So like here in Zambia, we've got one QTH at virology. So virology lab, they prepare the panels, and then they be able to send the panels to the facilities that have enrolled for that EQA program. So when they are sending out the results, the testing facility doesn't know what the results are. It's only when the results are marked that the laboratory or the testing facility will be told whether they are doing well or not. But then in an event where the laboratory has not passed or they haven't done well in that particular panel, the national sending laboratory has to write to them to come up with a corrective action so that they make sure that all those issues are sorted out before the results are sent out to the patient. So in a nutshell, the panels are prepared at virology here at UTH, and then they are sent to the testing facilities for assessing how they are doing the test.
So this is a reference laboratory
Yes.
we've been talking about.
Yes.
I hope that's clear, Dr. Onoya. I will now move to Violet Kunda.
Sorry, Dr. Mupeta. I think that the definition of the proficiency testing, but how is it working in Zambia? Because I remember in Kaoma sometimes back we had a case, a patient had been on treatment for 2 years, but when we conducted the testing at the hospital, it came out, the rapid test came out negative. I know it can be anything, but we really questioned the quality of the testing, especially testing being provided in the community. So do we, as Zambia, conduct the proficiency testing at all the levels?
Okay, so he really just wants to know if that program is going on in Zambia.
Yes, yes, it is.
Yes, so the answer is affirmative, Doctor.
So Dr. Onoya, the program is actually going on in Zambia, but the onus is on the facilities to actually enroll. So they will not force you to do it. You as a facility have to enroll. And then when it comes to community testing, this is where we have issues. For example, you're going to find that maybe some people, instead of waiting for the recommended, is it 15 seconds, they'll do it in 10, or they'll wait for 30 minutes after they've done everything and then come back to read the result. So we have issues in the way that we are actually conducting the testing. And this is why we are saying the 10th person must be sent to the lab as a way of checks and balances. Now, this also has not happened very well because in some facilities, it's not really practical. And also the other thing is yeah. Sorry about that. So, and also the other thing is, remember for the oral HIV test result. So if it is positive, I did it by myself in the community. When I come back, the facility must actually retest. So there are certain strategies that have been put in place to actually help us to handle this one. We may not be there yet, but at least there are some strides taken in the right direction.
Okay, thank you very much. I think just a reminder to all of us who are joining, especially us who are using lone gadgets, kindly ensure that you mute your devices so that you do not disrupt the session. Violet, can go ahead. Violet Kunda.
Thank you very much. My question goes to Mpanji. I just want to make a follow-up. I think the question that Dr. Onoya was trying to ask is about the program on HIV proficiency testing, where testers are supposed to be re-evaluated every 2 years, which has just begun. But before the testers are they are trained to be evaluated. The facilities where they are testing from are also supposed to be evaluated and certified. So
Yes.
as implementing partners, we would like to find out if there's a timeline to that program, and if there is, what time is it starting? And as in terms of the people that are doing the testing, as implementing partners, when do we have this cycle complete to ensure that the people who are at the facility or community testing have been trained in proficiency testing and they are testing from certified facilities? That's my question to you, Mpanji.
Okay, thank you very much. So I'm glad that in the presentation, the issue of SOPs and guidelines came about, because ideally what is supposed to happen, even before I answer your question, is that the testers, they have to go through the training materials and standards before the competence assessment is done. So technically the testers, they have to make sure that they read the SOPs, they understand the SOPs, and the person who's training them is actually confident that these people have actually read and understand the SOPs. Then secondly, the issue of before you even conduct competencies, that there has to be, you demonstrate to them how the test is done, so that they know exactly how it is done based on the SOP and based on what you are showing them. But then to answer your question, competency assessment, I don't know what MOH policy is, but generally in the lab, competence assessment should be done every year. So if a person is trained and the person who is training that person assesses that person, they're supposed to do like some form of, for lack of a better term, like a test, maybe where you give them maybe 3 or 4 non-results, and you give them opportunity to retest those non-results. What you see, you compare them with what you have as a standard. Then if that person passes and qualifies and you are very sure that that person actually is doing a good job, then you're supposed to come up with what she's mentioning in the slides, documentation and records. So if I train someone in June, I have to write it down that on the 20th of June, I trained somebody. Then a year later, that competence assessment has to expire. 2 years for us is is a long period of time. So we usually do it every year. So every year, regardless of the person, they have to undergo the competence assessment, and it has to be documented.
Okay, so thank you very much. So I think just in a nutshell, Mpanji is trying to say that it's a process which starts from training and then somebody being evaluated for competence and then re-evaluated again, which he says from the laboratory part is every year, and then ensure that we document and follow up, especially for those whose competences are expiring. Now, just to put you on the spot, whose job is it to actually follow up and ensure that, to see whose, certificate or license has expired?
So it depends on the setup, but I think the common denominators, depending on the facility, is that, for instance, in a big facility like UTH, there are supervisors. So a supervisor might follow up and ensure that that person doesn't go beyond a particular period of time without undergoing competence. But then in other facilities, there's what they call quality officers. So they're the ones who've got records of who's due for competence when, and they're the ones who follow up in addition to the supervisor. So it depends on depends on the setup, but I think in a nutshell, it's a supervisor and a quality officer within the facility.
And I think, Dr. Zyongwe, you talked about quality assurance teams, is it?
Yes, quality assurance teams, but in addition to that, our stakeholders, so the province, the district, they need to make sure that the staff who are conducting testing in their districts or in their provinces are actually competent and they have done their proficiency testing. In addition to that, at a health center, for example, the in charge is in charge of everybody. And so the in charge has to make sure that everyone conducting testing in her or his facility are also competent and they're producing actually accurate results. But the partners, the implementing partners, have also not been left out. We need to make sure that the people who are conducting testing on our programs have actually undergone training. They are trained to do the HIV testing, and we make sure that they're actually certified to, conduct the training. So everybody has a role to play. There is no one single person who has been given the task of QA.
Right.
Right.
Okay, so thank you very much. That is well explained. I will ask one more contribution or question before we move back to the polls. Anyone who has got a burning issue or question or contribution as well. It could be something that we can learn. All of a sudden, the fast mentors have become slow.
Maybe just a comment. I think in addition to what she's mentioned, I think the importance also of documentation and keeping records is very important for the lab. So I think I would encourage that if possible in the personnel files, when someone goes to check in the personnel files, if someone is testing, they should be able to see the competence test results, as well as maybe a document saying that this person has been certified because they passed in, so that at least people should be able to check in the personnel folder that it's there.
All right, thank you very much. So there is a contribution within the hub. Madam, you can introduce yourself. I don't know if you may need to come near the mic. Is it going to reach? Please kindly just come to this. Just there, just there.
Okay, good afternoon, everyone. My name is Edina. I'm one of the HNP students at Lusaka School of Nursing. I just wanted to find out what can be done, or how a person who has a partner who is taking ARVs and they have reached their viral suppression, but they choose not to disclose their status to the partner. When they go for an HIV test, they both come out negative because of the viral suppression. And this woman will take it, the partner is also negative, and go ahead and get married. But later on, seroconverts, probably because of lack of adherence, because of those non-disclosure issues. So how can this woman be helped in those related?
Okay, thank you very much. So there are several issues, I think, on the question at hand. There's the issue of, is a person an adult who is on ART and virally suppressed? Are there circumstances we expect a negative test, Banji? And then we'll move on to the other issues.
Yes. So the issue is also, it depends on how you interpret results. Because if you look at viral loads, you've got target not detected, less than 20 copies, and less than 20 copies. So when a patient comes in and then before they were detectable and then after, the results are showing that target not detected. What it just simply means that in the blood, the machine is unable to detect the virus, but the virus can be in other places, like inside the cell, in other places like the tissues and whatnot.
So now, just maybe to get it clear, because you said two things: virally suppressed, test HIV negative. The test you're talking about, the antibody.
The antibody.
So, do we expect an antibody test to be negative when somebody is target not detected, if the quality issues are taken into consideration?
I don't think so, unless otherwise. I don't think so.
Yeah, so if the test is correctly done, because this is an adult, there is less likely that the rapid test is going to come out negative. All right, unless if there are quality issues, which we are talking about today. So definitely they were supposed to make sure that they get the correct test. So it must have been something wrong with the testing. For an adult, once the antibodies are formed, they will be present for a long time to come. Yeah. Okay, so I think we can go back to the poll questions. And okay. So the poll questions will go back to the first one, and we can now vote again. And this time I'm going to allow people in the hub to vote as well. The first poll question was as follows: which of the following is true? Misdiagnosis of HIV in Zambia is hypothetical. B, false positive and false negative results are possible. D, all results are correct as long as internal quality control is passed. D, quality assurance can improve accuracy of HIV test results. So we can go back to the first poll and okay, we can please go ahead and vote. Okay, so all of a sudden a few people have voted. It's like people are unsure. Or is it that my thing is behind my voting scheme? Chatonda, it's showing that 59 out of what has voted.
So as you can see, I don't know what's going on, but 53.
Yes,
59 people.
there's something wrong with this.
Yeah.
Okay, yeah, this is the true representation. So Dr. Zyongwe, any thoughts? We've got almost 90% going for D, including the hub, and then 3% going for A, 2 for B, and then C, 5%.
Okay. So the answer is D, and that's because we know that quality assurance actually can improve the accuracy of the test results. This is what we've been talking about. So in terms of misdiagnosis, just our case itself shows us that it's not hypothetical. It actually does happen. And then when you're talking about lay counselors, remember that anybody who is conducting the testing can actually produce a false negative or a false positive result if they don't follow the quality assurance system very, very well. And when you're talking about internal quality control, so yes, for example, what I came across, they will actually put in the blood first on the determine, and then later they'll come and put the buffer, or if there's no buffer, they'll drop a few drops of normal saline or something. So the blood would have moved before even, the buffer gets there and all. So even if when I did the quality control test strip by myself, it was okay. But because of the way I have now done it, with a person's blood, it now gives a false negative result.
Thank you. So the next poll question is poll number 2. Which of the following is true? Quality assurance activities are improvements you make after performance assessments. Then B, planning is part of quality assurance. C, quality assurance has many steps, including how facility is organized. D, quality assurance refers to process control only during the testing. So we can go ahead and poll. So this one is still confusing. I think the before and after, it's almost the same results. Hey, there's somebody. Okay, so I've got a number who have voted, and I can end the poll. About 63% have gone for C, and then a good number, which is almost 40%, have gone for B. So B and C are really, really, competing. Dr. Zyongwe, please help us. We don't know if people have learned or unlearned on this question.
I'm not sure whether I talked about this in a quality manner or not. But the correct answer is actually B. And this one was a little bit tricky because I just wanted to get people to think a little bit outside the box. So when you're talking about B, planning definitely is part of quality assurance, as we saw from the diagram we picked from the WHO 5Cs guidelines. But C, however, is talking about how the facility is organized. It is not so much how the facility is organized, but how the system is organized. So in a facility, how have you organized your quality assurance system? That is what we are talking about, and not the organization of the facility, whether you have an in charge and a second in charge and things like that. So the correct answer is B. We are actually talking about planning.
Okay, thank you very much. So we'll go now to the third core question, the third and last, which reads, which of the following is false? National Reference Lab produces QC specimens and external quality assurance scheme panels. B, use of a timer testing is not critical if you are highly experienced HIV testing. You're highly experienced in HIV testing. C, implementing partners need to control QA activities in their supported facilities. Then D, quality assurance teams should be in place at every level. So here we are looking at which one is incorrect. Hey, Bwana Chatonda, where's your poor question? Okay. There was a correction though on the third, is it?
On C, yes.
On C. Yeah, so just a correction on C. It's supposed to read, implementing partners need to be involved rather than to control, need to be involved in quality assurance activities in their supported facilities. So which one is false? Split of a second. The first mentors have not voted. Okay, so quite a number have voted, and Dr. Zyongwe, we've got 98% going for B and only 2% going for C.
Yeah, so the correct answer is actually B. And this is where, in my experience of going around, we find that half the time we don't really have timers. So maybe they feel they're very, very experienced, and they'll just do the testing and eventually, you know, come up with some arbitrary time and say it's now 15 seconds so we can read the result. So B is the correct answer. C is not correct, despite a few people picking C, because the implementing partners actually need to be part of the QA system or activities at the site. Remember that they help us to make sure that we have the commodities, they provide the registers that we use and different documentation or forms or templates that we use, and they actually support us in doing a lot of things, so we cannot exclude them. Even the community is a very big player, a key player in quality assurance. They need to demand for quality services as well.
Thank you very much, Dr. Zyongwe, for that wonderful presentation. And I think we are now up to date when it comes to quality assurance issues, both at the national level and in our facilities. I would like to thank Mr. Mpanji for coming through, and also everyone in the network who have joined and participated and made this a lively discussion. Special mention to the HIV mentors who are meeting in Lusaka. Indeed, they proved to be ready to take up the mantle in the management of HIV in our country. Next week, we are going to discuss ART in children. The main objective will be the emerging issues, and it will be presented by Dr. Chalilwe Chungu. From all of us from the Hub, it's goodbye and see you next week. Thank you.